Hello, welcome and thank you all for being here tonight. Being an EMT, just like everybody else in the room, I like to stay informed about any new proposed training requirements or additions to our scope of practice as EMTs. That being the case, in the next few minutes, I'm going to explain some new proposals that were brought forth on June 7th, 2008 by the Department of Health. And those proposals will seek to expand upon our training curriculum and scope of practice. Now, the public comment period is going to be open for these new proposed changes until September 7th of this year. So it's important to learn what the proposed changes are and to actually comment on them, and those can be submitted through the NJ Register to the Department of Health. Now, there are four major classes that a lot of EMTs were required to have before, but separately from the EMT training program. The first of those was Hazardous Materials Awareness, or HAZMAT. And essentially that's a foundational class, and it takes the brand new EMT through the hazards and the risks posed by any sort of incident that involves hazardous materials, chemicals, gasoline, industrial waste, anything of that nature. The course also goes over the use of the ERG, or the Emergency Response Guide, which is an important reference manual that we use to identify what containers are carrying what chemicals. It also goes over various protocols for containment and decontamination in incidents like that. That's roughly a 4-hour course as it stands now. The second course that they want to include in the curriculum is going to be Weapons of Mass Destruction Awareness, or another name for it is CBURN Awareness, which stands for Chemical, Biological, Radiological, Nuclear, and Explosive Awareness. That class is similar in HAZMAT to what it goes over, except that that information is geared towards incidents of more of a terroristic nature. So if somebody purposely released hazardous chemicals or set off a nuclear device or an explosive device, this course will teach you some of the basics how to identify those kind of situations and goes over some more specific details of what to do in incidents of that nature. Next is Incident Command System Level 100, or ICS 100. And that's another foundational course which gives an overview of how an emergency response is supposed to be organized and operated as far as leadership and management of the resources is concerned. This will get into a very basic idea of how to organize emergency medical services, police, fire, emergency management, any other agencies that might come together in a large incident. The last class that they want to add in is called NIMS 700, or National Incident Management 700. And that's another foundational level course, but this one is geared towards introducing people to how multiple large agencies will work together in a very large incident, something that might cross state lines and or involve multiple federal agencies. An example would be something that a small plane crash, even if it only involved a few people, a small plane like a Cessna, and only involved agencies within one township, still the FAA would have to come in as part of the investigation, just like the State Office of Emergency Management. That would actually be a situation where NIMS would be utilized. And the overview course will tell you specific procedures to activate that and who to coordinate with in situations like that. Now, altogether, the HAZMAT right now is about 4 hours, the WMD is another 4, and ICS 100 and NIMS combined is roughly another 4 hours. So that's 12 hours total of additional training they want to add into the curriculum. As of right now, it's a little unclear as to whether it's going to be a straight 12 they're going to add to our already 120 hours, or it's going to be more condensed. There's no official word on that as of yet. In addition to the training requirements, the Department of Health also wants to add some more advanced protocols to our curriculum as it stands. The first thing they want to add is epinephrine auto-injector devices, or more commonly called EpiPens. These are auto-injectors that are designed to assist somebody that's having an anaphylactic reaction by relieving the symptoms associated with that. Now, the current protocols allow us to assist somebody with the administration of it to themselves. So in other words, the patient already has to have one on them, has to be prescribed the medication, and they also have to be able to somewhat administer it to themselves. The change that the Department of Health wants to put in would actually allow basic life support ambulances to carry the medication on our own with some additional training, and then administer it in cases where a patient may not be prescribed the medication, but definitely qualifies for an emergency situation. The next item that they'd like to add to our scope of practice are called nerve agent antidote kits, or NAAKs. These kits are actually an antidote kit that's been developed by the military and is now being used in the civilian sector for emergency response. It's a 3-drug antidote kit that's designed to counteract the effects of some chemical and nerve agents that might be used in a terroristic attack. These kits are specifically for the EMS responders and the crew members, though. They're not for patients. These are stopgap maneuvers only, and they're not designed to allow a responder to stay in a scene where these kind of elements are present. Instead, this is supposed to be something that's administered on the spot, and it's designed to give the EMTs and other crew members a chance to get in their truck and get out of the way. The final thing that the Department of Health wants to add to our scope of practice are advanced airways. Currently, we're allowed to use 2 basic airways. However, the Department of Health has decided that a more advanced airway would help improve disposition of some patients upon arrival at hospital, specifically those that are in cardiac arrest or have multi-system traumas that require advanced airways in order to maintain adequate ventilations. The first of these 2 devices is called the LMA, or the laryngeal mask airway. And this device is just a single tube with a seal at the bottom of it that actually goes over the larynx and forms a soft vacuum seal. And when a bag valve mask is attached to it, allows direct ventilation into the lungs. This is inserted blindly, so you're not required to use a scope like the paramedics do for their endotracheal tubes. You don't have to see the vocal cords in order to place this. The second advanced airway device that the Department of Health wants to add to our protocols is called the combi tube, or a dual lumen airway. And this device is essentially 2 endotracheal tubes, which is really nothing more than a soft tube, that are fused together and can be inserted into the throat. One tube will actually go down the airway itself, while the other will go down the esophagus towards the stomach. Now, in the middle of those 2 tubes, there's a seal. When inflated, that'll actually close off the area right around the larynx and prevent any air or any gastric discharge from escaping from the body. There are also 2 valves, one for either tube. When you attach the bag valve mask to the top port of the combi tube, you have to open up one valve, begin ventilations, and then listen in the lungs. If you hear breath sounds in the lungs, that means you selected the correct valve, the correct tube, and you can continue ventilating for the patient. However, if you hear breath sounds in the stomach or the abdominal region, that means you picked the tube that it was inserted down the esophagus. You have to stop what you're doing, close the valve, open up the other valve, and start ventilating again. After that, you're going to listen once again for breath sounds in the lungs. As long as you're getting breath sounds in the lungs, the placement is good, you picked the correct valve, and you can continue. Now, these 2 devices are geared towards improving patient disposition upon arrival at the hospital. It'll allow greater oxygenation and ventilation for individuals that are in cardiac arrest or that have suffered severe traumas. Now, all this additional training and these added protocols will increase our training time and add to the curriculum. Again, it's unknown exactly how much. However, it's probably a safe bet to assume at least another 15 hours in addition to our 120 hours currently. These protocols are actually being put in to try to bring New Jersey state protocols up to the national standard. There are a lot of people that believe the state is many years, perhaps even decades, behind the rest of the country in developing their EMS protocols, and this is one step amongst many that need to be taken in order to bring us up to current standards. Are there any questions? Thank you all for being here.